Hello, everyone. Welcome to the Cannabis and Road Safety session. My name is Paul Bose, and I'll be the moderator for this session. We just have a few housekeeping items to go through quickly before we get started. There's conference interpretation service available. If you click on the planet/sphere icon at the bottom of your screen, and then you can select the language of your choice. I can tell you that presentations in this session will be in both official languages. If you have questions, we'll try to get specific questions at the end of each talk, or hopefully there'll be time at the end, but you have to put them in the Q&A tab, not the chat tab, the chat box. If you want to, throughout the conference, if you post to social media, use the hashtag at CARS PRI 2021, and all of those posts will appear on the social wall in the lobby. So we will do a Q&A after, and then we're going to ask all the speakers to turn their cameras off, and then when we get to the end for the Q&A, we'll turn all the cameras back on so that people can see everyone. So we might as well just get started. So I would invite Robin Robertson, the president and CEO of TURF, and Ken Linder-Henson, vice president of accident benefits and bodily injury claims from Desjardins Insurance. Robin?
Okay, thanks very much, Paul. There we go. Okay, so I'm very pleased to be with you. I'd like to thank everyone for joining us and Paul for moderating. I think we've got some different perspectives and data to share with respect to marijuana and road safety. I'm going to speak about current data and trends relative to concern about the issue, as well as prevalence with respect to self-reported behavior and fatalities. So, for some context, I'm going to provide a few data points with respect to drug-impaired driving generally to help put the marijuana and driving data in context. So you'll see that concern has increased and decreased at various points in time. Back in 2008, when we had drug driving legislation and the DRE program introduced, concern was higher. It waned really through until 2014, and in the years leading up to legalization, 2017, 2018, and immediately post legalization in 2019, you can see that concern about this particular issue was higher. To provide some insight in terms of how many drivers and what proportion of drivers are using drugs and driving, you can see that the first three data points here are really focused around use, not specific to driving. So you can see that almost 1 in 5 or more than 1 in 5 Canadian drivers reported using marijuana or hashish in the past 12 months, with many of them being in younger age groups, and a smaller proportion admitted to using illegal drugs, as well as prescription drugs that might affect their driving. But when we look at prevalence of use within 2 hours of driving, or within 2 hours of using marijuana, reporting having driven, you can see that 4.5% of drivers said that they did this after using marijuana. A larger proportion, 14.8%, admitted to using over-the-counter medications, and a smaller proportion, less than 3%, admitted to using prescription drugs and then driving. So you can see that the percentages seem quite small, but we need to keep in mind that that 4.5% using marijuana and then driving is of 26 million drivers, so a rather large number. Looking at trends in marijuana and driving really over almost 2 decades, you can see in the earlier 2000s, lower proportions, a small peak in 2010, But really since 2015, we've seen some increases, again, particularly with respect to leading up to legalization. So immediately following legalization, you can see that almost 7% of Canadians reported using marijuana and then driving within 2 hours in the past 12 months. In 2019. And since 2015, we've also asked about the combined use of marijuana and alcohol. So again, you can see small percentages peaking in 2019 at 3%, and then a decrease into 2020. On this slide, I've included some information about testing rates for the presence of drugs in drivers, because our testing rates have changed significantly in the last 2 decades. And that's important to know when interpreting the data. So in 2017, more than 80% of drivers killed in road crashes were tested for drugs. And when we look at the 2017 data, about 1/3 of drivers tested positive for any drug in 2000 when testing rates were lower. But in 2017, more than 40% of drivers killed in crashes tested positive for any drug. And you can see there the breakdown with cannabis being the largest or most common drug found, followed by CNS depressants, and smaller categories for stimulants, as well as narcotic analgesics, which was about 22%. Some of the characteristics that we see with respect to drugs in fatal crashes, we see a slight difference between males and females, but perhaps a smaller difference than we might expect, with 44% versus 40%. We see that males are more likely to test positive for cannabis, and positive drug tests are more prevalent in drivers under the age of 35. And in fact, with respect to testing positive for drugs, it's drivers aged 20 to 34 who are most likely to test positive. Not surprisingly, we see cannabis is more prevalent in younger drivers, older drivers. We tend to see more often central nervous system depressants. And again, the difference between fatalities on weekends versus weekdays is not that different, in sharp contrast to what we see with alcohol. So this is just really a quick look at drug categories by age. So again, marijuana, CNS depressants are most common among, or stimulants are most common among younger age drivers. Older age drivers, it is the depressants and narcotic analgesics. So definitely different types of drugs depending on age. Now, if we're looking specifically at marijuana, in 2017, about 1 in 5 fatally injured drivers who were tested for drugs tested positive for marijuana. Again, males more likely to test positive than females. And when you look at trends with respect to sex, we see an increase from 2000 with respect to males as well as females. So 14.4% of males in 2000 versus 23% in 2017. And again, females rising to more than 11% in 2017. Looking at the number of fatally injured drivers that tested positive, again, we're seeing a fairly steady upward trend, a slight dip with respect to 2010. And again, that may be, you see that downward decline from 2008 to 2010, which was when our initial drug driving legislation was passed. And again, looking by age, the 16 to 19-year-olds and the 20 to 34-year-olds are definitely larger proportions are testing positive for marijuana among fatally injured drivers over the years as compared to older age groups. Just a quick look at how we're doing with marijuana versus how we're doing with alcohol. And you can see with alcohol, we've had a fairly steady downward trend. Conversely, with marijuana, we are seeing that upward trend And looking forward post legalization, it'll be so important to understand, where the trend with marijuana is going. So some very preliminary data from our 2018 National Fatality Database. And I would encourage you to check out Steve Brown's presentation from TURF, who will talk about this a little bit more. But basically, we have some preliminary data for 2018 from 8 jurisdictions, which represents the majority of Canada. And we can see the percentage of fatally injured drivers testing positive for marijuana was 21.7%. So that's a slight increase over 2017. So again, post legalization, initially we're seeing a slight increase. And when you look at the data between January and October, which was pre-legalization and post legalization, we actually saw fewer fatally injured drivers testing positive for marijuana post legalization. But if you look specifically at the younger age groups of 16 to 19, we see that post legalization, there was indeed an increase. So to wrap up, concern continues to be high, although it seems to be waning somewhat. And that concern is justified given the self-reported prevalence that we're seeing of driving with marijuana, as well as marijuana combined with alcohol. So that steep increase in 2019, that's leveled off in 2020. So that's potentially good news, but again, we're seeing an increase in the proportion of fatalities testing positive for marijuana. So our self-reported data very much mirrors our fatality data. And again, it seems that the increase is most pronounced for young drivers. So I will stop there and stop sharing and turn it over to Ken from Desjardins to share his presentation.
Thank you, Robin. Just sharing my presentation. I think we should be good to go. So I will get started. An observation that I'll make very quickly, not surprisingly, I'm going to talk about marijuana impaired driving opinions and behaviors in Canada. And based on what you just shared, Robin, we see a strong correlation between behaviors and opinions and outcomes and actions, which I think we would expect. A few details about who I am. At Desjardins, I'm responsible for helping our clients recover from injuries that are sustained in motor vehicle collisions. So unfortunately, in my role, I see firsthand the devastating physical and psychological impacts of impaired driving on our clients and on our communities. And at Desjardins, we truly believe that motor vehicle collisions, and I use the word collisions versus accidents for a reason, we believe that they're preventable. We believe that they're avoidable. And that's why Desjardins is committed to reducing injuries and fatalities on the road through our actions and through participating in events like this. So it's really a pleasure to be here. A couple of details, and maybe a little bit boring, but about who Desjardins is before we get into the really interesting stuff. We are Canada's first credit union. We were established in 1900. We're Canada's largest financial cooperative with 7 million members and clients. We have over 50,000 employees, and we offer a broad range of financial services. What I would highlight here, we're not shared on the stock exchange. We exist for our members and our clients. So as a cooperative, it's in our best interest to do what we can to improve things for the community and for the public as a whole. Now, looking at today's data, we've been conducting road safety surveys now with Canadian drivers for the past 6 years. Our surveys look at driving behavior, focusing on 3 main topics. First is drug impaired driving, and I'm going to focus on the marijuana aspect today. We look at distracted driving, and we look at vehicle safety technology. The 2001 survey results are going to be published in the fall, so they're not finalized, but I will be sharing today results from both 2020 and 2021. The survey we feel is statistically significant. It's about 3,100 Canadians that were surveyed between the ages of 16 to 74. So now let's jump into the conclusion. So I'm going to start off with some good news. We see that Canadians know and understand the dangers of marijuana impaired driving. About 9 out of 10 Canadians are concerned about marijuana impaired driving, and most understand the dangers of driving under the influence, with 84% agreeing that it impairs driving skills. So there's an acknowledgement that it's an issue and an acknowledgement that it affects driving abilities. If we look now at why aren't 100% of Canadians concerned, about 40% just don't think the frequency is high, and 30% say they don't think it's a dangerous activity. Now, right here, you see two opportunities for us to create more education and awareness about the true impacts of marijuana impaired driving. If we peel back the layers, we see that age really matters. Only 82% of those between the ages of 16 to 34 years of age were concerned, compared to 93% of those between the ages of 55 to 74. So this is coherent with some of the findings, Robin, that you had in your presentation. And 21% of drivers aged 16 to 34 don't believe marijuana impaired driving, or that it impairs driving, compared to 10% for those aged 55 to 74. So what can we take away from these findings? It confirms that education and awareness are important, particularly for Canadians between the ages of 16 to 34. The question I think we need to ask ourselves is, what can we do differently to assist with the education and awareness of these younger drivers? So now I'm going to move on to some of the other results. Canadian drivers do feel that progress has been made, and they have increased confidence in police services to combat the issue. This is likely as a result of some increased fines and consequences. However, there's still some concerning results. Of those who admitted to driving high, a third of them did so in the last 12 months. Now, on a slightly more positive note, only 22% of Canadians feel that there's enough education and information about marijuana impaired driving, and 57% of Canadians want more information on marijuana impaired driving. Maybe a surprising result when we look at those Canadians who want more information. For the younger Canadians between the ages of 16 to 34, it jumps up to about 61%. So there's an interesting dynamic happening here. We see that younger drivers are more likely to think that marijuana impaired driving doesn't impact their driving skills, while at the same time, they're interested in getting more information on marijuana impaired driving. So from my perspective, this reinforces both the need and the opportunity to do more and to do things differently with younger drivers. Now, one of the most concerning results, and again, there's some overlap here between our two presentations, dangerous driving behaviors lead to other dangerous behaviors. People who drive under the influence of marijuana are more likely to drive under the influence of prescription drugs and over-the-counter drugs, about 3 times more likely. And people who drive while distracted by a cell phone are also more prone to driving under the influence of marijuana, prescription drugs, or over-the-counter drugs. So this represents a very dangerous accumulation of risk. In insurance, we often see this connection. Drivers who were involved in drug or alcohol impaired driving may have also been distracted, may have also been speeding. What I would ask all of ourselves is, what can we do today? And I would say, if we witness dangerous behavior, and more than likely it's going to be things like people speeding, whether let's say we're in the car with our family or friends, someone who's speeding, maybe who's tempted to take a look at their cell phone or their smartphone. I think it's important for all of us to remind the people who are with us in the car, and even ourselves when we're tempted to do it, that this activity isn't okay, and that we need to change our behavior. And through changing our behavior and our actions, it can help save lives. If I switch gears a bit to what Desjardins is doing to address impaired driving, education and awareness, we're conducting surveys, we do our own campaigns, we're collaborating and partnering in events like this and with TURF and CARSP. We're also investing in research. A very important thing that we do within Desjardins, and I don't want this to be a sales pitch, so I'll go through it very quickly. We were the first insurer in Canada to introduce telematics. For those of you who aren't familiar with telematics, it puts the ability to understand your driving habits into your own hands. So you can see on your smartphone, where did I maybe speed? Where was I going faster than I should have? Where did I have excessive braking? Where did I have excessive acceleration? By putting that information into drivers' hands, it gives them the ability to change their behavior. And with Desjardins, if their behavior improves or they're good drivers, they will see a benefit in terms of premium discounts. A moment on how does impaired driving impact your insurance. It really depends on the circumstances. It can be a surcharge on your insurance premium. So if you get your renewal, instead of being $1,000, it could be $1,100, $1,200, or $1,300. There could be coverage restrictions, so it could impact collision or comprehensive coverage. if you have something as serious as a criminal conviction, you can be non-renewed with your insurance company or not even get insurance in the regular market and have to go to what's called the residual or high risk pool, which can translate into significant insurance costs, 2, 3, 4 times what you might have otherwise been paying had you not had that criminal conviction. And these impacts can last from 3 to 10 years. So there's a strong incentive, if for no other reason, and of course there are lots of other reasons, not to drive impaired because of the impacts it can have on premium. If I move to some of the key takeaways, the question for this conference was, are we there yet? I think the answer is no. Are we making some progress? Yes, but we still see an opportunity. Marijuana impaired driving remains an issue. Addressing marijuana impaired driving needs to be done differently for the different age groups. It speaks to the one size fits all solution or cookie cutter approach is not going to work. We see that perceptions and behaviors are different for the youth than maybe the older population groups. So what do we need to do differently? I may begin to be unfairly stereotypical here for a moment, but if you look at what we need to do from an educational awareness perspective with a 16-year-old versus a 7-year-old, I think it's probably not a surprise to assume that the approach we need to take will be different. So it will influence our actions and the things that we will take and the things that we will put in place. Dangerous behaviors are linked to other dangerous behaviors. So if we can change and influence one behavior, it could potentially reduce other dangerous behaviors as well. And last but not least, vigilance, collaboration, and cooperation are needed to continue the education and awareness efforts. I don't believe that any one organization is going to be able to do it alone. We need to continue to work together collaboratively if we hope to address some of the issues that we've talked about today. And that's it for me. Thank you very much for giving me the opportunity to share some of the results and some of the perspectives from Desjardins.
Thank you, Ken and Robin. Next up, we have Matthew Sinat, who's the drug coordinator for the Sûreté du Québec. Mathieu?
Bonjour tout le monde, bonjour Paul, merci d'être le modérateur aujourd'hui et merci aux autres participants de nous permettre de connaître un peu leur expertise dans leur domaine respectif. Donc, je me présente, mon nom est Mathieu Sinat, je suis coordonnateur drogue à la Sûreté du Québec. Mon rôle est vraiment au plan stratégique et au plan de l'intervention policière. Donc, aujourd'hui, ce que je vais vous parler, c'est un peu comment ça se passe sur le terrain lorsque les policiers interviennent avec des gens suspectés d'avoir consommé des drogues, dont entre autres le cannabis. Je vais partager ma présentation. Donc, tout est fonctionnel? Donc, je me suis présenté, mon nom est Mathieu Sinat, comme je vous disais, coordonnateur drogue à la Sûreté du Québec. Au niveau de notre mission à la Sûreté du Québec en matière de conduite avec les capacités affaiblies, à la direction de la sécurité routière, nous avons un mandat surtout d'éducation, de prévention et d'intervention, ainsi que de communication auprès des citoyens. Notre but à la fin de l'année, c'est vraiment s'assurer que le bilan routier soit le meilleur possible, avec le moins de décès sur les routes et le moins de blessures sur les usagers de la route. Donc, au niveau de la présentation aujourd'hui, je vais vous parler de l'aspect légal de la conduite avec les capacités affaiblies par la drogue, les outils de dépistage que les policiers ont à leur disposition, les stratégies de collecte de la preuve en matière de conduite capacité affaiblie, les enjeux que font face actuellement les organisations policières en matière de capacité affaiblie par la drogue et certaines données statistiques que nous avons.
Matthew, just let me know when to advance your slides.
Ah, OK. Parfait. Donc, Donc, en matière de conduite avec les capacités affaiblies par la drogue, les policiers au Canada ont le code criminel qui donne certains pouvoirs pour dépister les conducteurs sous l'effet de la drogue et recueillir de la preuve. En plus du code criminel, chaque province canadienne a certaines lois propres à leur province pour donner aussi aux policiers des pouvoirs en matière de suspension de permis de conduire, saisie du véhicule et les infractions au Code de la sécurité routière. Donc, au Québec, c'est le Code de la sécurité routière qui est appliqué par les policiers suite à une intervention en matière de capacité affaiblie. Depuis 2018, suite à la légalisation du cannabis, il y a de nombreux changements qui ont été apportés au Code criminel et au Code de la sécurité routière pour s'adapter à la légalisation du cannabis et donner de nouveaux outils aux policiers pour le dépistage. Au Code criminel, c'est l'article 320.14 qui interdit la conduite avec les capacités affaiblies par la drogue. Cet article est divisé en 4 paragraphes, soit la conduite de moyens de transport avec la capacité affaiblie à un quelconque degré. Donc, peu importe le degré d'affaiblissement des capacités, il s'agit d'une infraction au Code criminel, tant que ce soit avec l'alcool ou la drogue. Il y a aussi ce qu'on connaît en matière d'alcool, soit le 80 mg, le 0,08 et plus au paragraphe B. Et il y a aussi des infractions en matière de concentration de drogue dans le sang, ainsi que d'effets combinés de drogue et d'alcool. On a au niveau du sang certains taux qui sont interdits dans le sang. Soit au niveau du THC, on parle de 5 nanogrammes, et il y a différentes drogues comme le LSD, la psilocybine, la psilocine, différentes drogues que tout niveau détectable dans le sang constitue une infraction criminelle de conduite avec les capacités affaiblies. En matière de cannabis, on parle de 5 nanogrammes ou de combinaison de 50 mg d'alcool et de 2,5 nanogrammes de THC. Donc, c'est l'infraction au Code criminel fédéral. En matière de Code de la sécurité routière, depuis 2018, certains pouvoirs sont applicables aux policiers en matière de suspension de permis lorsqu'il y a une évaluation réalisée par un agent évaluateur. Donc, je vous parlerai un peu plus tard de en quoi consiste une évaluation réalisée par un agent évaluateur. On peut changer la diapo. Parfait. Donc, lorsque les policiers interviennent auprès d'un conducteur qui est suspecté d'avoir consommé de la drogue, plusieurs éléments sont analysés par nos policiers sur le terrain, soit l'observation de la conduite, le comportement général du conducteur, les signes et symptômes tels que les yeux, le langage, les mouvements, la présence de substances dans le véhicule ou l'odeur, des objets de consommation, des déclarations, soit de témoins ou de conducteurs. Donc, tous ces éléments-là sont pris en compte par les policiers sur le terrain pour déterminer est-ce qu'on doit utiliser des outils de dépistage ou on a suffisamment d'indicateurs pour procéder à l'arrestation de la personne pour conduite avec les capacités affaiblies. C'est vraiment la première question que les policiers doivent se poser lorsqu'ils sont en intervention auprès d'un conducteur suspecté d'avoir consommé de la drogue. Lorsque les policiers soupçonnent que la personne a consommé de la drogue, il y a 2 outils mis à leur disposition, soit les épreuves de coordination des mouvements et le MDDA, soit le matériel de détection de drogue approuvé. Ces outils-là, on va les voir en détail en quoi ça consiste. Lorsque les policiers ont des motifs raisonnables de croire, ils peuvent arrêter sur le champ la personne sans nécessairement utiliser les outils que je viens de vous mentionner. En quoi peut consister des motifs raisonnables de croire si la personne a beaucoup de difficultés à parler, dégage une forte odeur de cannabis, par exemple, a un langage, une démarche et plusieurs éléments accumulés peuvent permettre d'avoir des motifs raisonnables de croire. Des motifs raisonnables de soupçonner, c'est plutôt un simple soupçon, soit une odeur ou un comportement particulier. Donc, au niveau des 2 outils de dépistage par les policiers sur le terrain, le Code criminel permet à ces policiers-là de donner l'ordre à la personne, avant qu'elle soit arrêtée, de se soumettre à 2 mesures, soit les épreuves de coordination de mouvement, comme je vous mentionnais, ou le matériel de détection de drogue approuvé, qui est un appareil salivaire. Donc, le Code criminel le permet depuis 2018. Donc, c'est récent. Avant 2018, c'était seulement les épreuves de coordination de mouvement qui étaient utilisées par les policiers. En quoi consistent les épreuves de coordination de mouvement? Ce sont des tests standardisés qui sont administrés en bordure de route. Donc, lorsque les policiers ont des soupçons, peuvent donner l'ordre à la personne de se soumettre à ces tests-là. Au Québec, actuellement, on a plus de 90% de nos policiers sur le terrain qui sont formés pour utiliser les épreuves de coordination de mouvement. Depuis les dernières années, tous les policiers qui sont formés à l'École nationale de police du Québec ont la formation d'épreuves de coordination de mouvement dans leur induction, donc dans leur formation initiale. Ces tests sont 3 tests, soit le test du nystagmus du regard horizontal. Donc, les policiers vérifient les yeux de la personne. Le test marcher et se retourner, soit le test de la démarche, marcher sur une ligne et se retourner, et le test de se tenir sur un pied. Suite à l'administration de ces 3 tests en bordure de route, les policiers recueillent des indices qui leur permettent de dire la personne devant moi, avec l'ensemble des observations, a les capacités affaiblies. J'ai des motifs de croire qu'elle a les capacités affaiblies et j'en ai suffisamment pour procéder à son arrestation et l'amener soit devant un agent évaluateur, que je vous expliquerai un peu plus tard c'est quoi, ou soit de fournir un échantillon sanguin. Donc, c'est ce en quoi consistent les épreuves de coordination de mouvement. C'est actuellement la seule méthode utilisée au Québec par les policiers pour dépister la capacité affaiblie par la drogue lorsque les policiers ont des soupçons. Lorsque les policiers ont des motifs raisonnables, ils procèdent à son arrestation et utilisent différents autres outils. Le deuxième outil permis au Code criminel est le matériel de détection de drogue approuvé. Cet appareil est vraiment des tests salivaires que les policiers ont le pouvoir d'ordonner à la personne de se soumettre. Donc, c'est permis depuis 2018. Ces appareils salivaires-là détectent le cannabis, la cocaïne et la méthamphétamine. C'est les 3 seules drogues qui peuvent être dépistées. Il y a certaines provinces canadiennes qui utilisent ces appareils sur le terrain pour déceler la présence de drogue dans la salive des conducteurs. Par contre, actuellement au Québec, on n'a aucune organisation policière qui utilise les appareils salivaires pour des enjeux légaux et opérationnels. L'appareil salivaire permet de déceler une présence de drogue dans l'organisme de la personne. Cette présence-là peut ne pas être contemporaine. Ça peut être une présence de drogue qui date de quelques heures, voire quelques jours, et ça ne donne pas suffisamment d'outils pour procéder à l'arrestation de la personne. Donc, on doit tout de même procéder aux épreuves de coordination des mouvements en bordure de route pour procéder à l'arrestation de la personne si on acquiert des motifs raisonnables de croire. Donc, pour ces raisons-là, ces appareils ne sont pas utilisés actuellement au Québec. Une fois que la personne est arrêtée, soit par motif raisonnable de croire ou suite à l'administration des ECM qu'on peut qualifier d'échouer ou que le policier a suffisamment observé d'indices pour arrêter cette personne, les 2 alternatives possibles actuellement au Code criminel sont se soumettre à une évaluation par un agent évaluateur ou fournir un échantillon de sang. Donc, lorsque la personne est arrêtée, elle peut se soumettre à une ou l'autre et même aux 2 mesures prévues dans le Code criminel canadien pour la collecte de la preuve en matière de capacité affaiblie. On va détailler en quoi consistent les 2 mesures au niveau de l'agent évaluateur. Les agents évaluateurs sont des policiers spécialement formés pour amener une preuve de conduite avec les capacités affaiblies par la drogue. Ce sont des policiers qui sont formés au Québec à l'École nationale de police du Québec. C'est une formation assez complexe qui dure plusieurs semaines, une formation théorique ainsi qu'une formation pratique. les agents évaluateurs spécialement formés font des évaluations sur des sujets réellement intoxiqués. Donc, on a des gens réellement intoxiqués que nos agents évaluateurs évaluent pour essayer de déterminer quelle catégorie de drogue cette personne-là a consommé. Donc, les agents évaluateurs sont présents aux États-Unis depuis les années 70, au Canada depuis 2008. Donc, ça fait plusieurs années que le programme d'agents évaluateurs existe. C'est un programme là, américain à la base qui est maintenant disponible au Canada depuis 2008. Donc, l'agent évaluateur, ce qu'il fait, il fait un protocole d'évaluation en 12 étapes. Donc, le protocole permet de vérifier à l'étape 1 si la personne a de l'alcool dans son organisme. Le policier agent évaluateur ensuite fait une entrevue avec la personne ayant procédé à l'arrestation, le policier, pour acquérir certains éléments et voir comment ça s'est passé, qu'est-ce que le policier a observé sur le conducteur. Ensuite, on entre avec le sujet. Il pose des questions au sujet, observe le sujet, vérifie les yeux du sujet, prend le pouls. Ensuite, on a différents tests qui sont faits au niveau des yeux. On a des examens d'attention divisés. Ce sont comme un peu les épreuves de coordination des mouvements faits en bordure de route. Par contre, ce sont des épreuves beaucoup plus détaillées et on a beaucoup plus de tests qui sont faits à l'agent évaluateur pour vérifier si la capacité de conduire de cette personne-là est affaiblie. Ensuite, on a des signes vitaux qui sont pris, soit la tension artérielle, la température corporelle et encore une fois la prise de pouls. L'examen dans la chambre noire, ensuite, au niveau de la dimension des pupilles, les cavités buccales et nasales, si on a des résidus de drogue à ces endroits-là. On vérifie le tonus musculaire, les sites d'injection, etc. Ensuite, une fois ce protocole qui dure environ 45 à 50 minutes, 45 minutes à 1 heure effectué, l'agent évaluateur doit émettre une opinion, à savoir qu'est-ce que la personne a consommé, suivant son protocole qui a été suivi de façon rigoureuse, doit émettre une opinion sur la catégorie de drogue que cette personne-là a consommée. Une fois que la catégorie de drogue est identifiée par l'agent évaluateur, il y a le prélèvement de substances corporelles qui est effectué, soit de l'urine ou du sang. C'est ce protocole-là, ainsi que le test d'urine et de sang, permet d'amener une preuve de conduite avec les capacités affaiblies par la drogue. Au niveau des drogues possibles pour l'agent évaluateur, il y a les dépresseurs du système nerveux central. Ce sont les 7 catégories que l'agent évaluateur peut émettre comme opinion à la fin de son évaluation. Dépresseur du système nerveux central, inhalant, anesthésique dissociatif, cannabis, stimulant du système nerveux central, hallucinogène et analgésique narcotique. Chaque catégorie de drogue produit des signes et symptômes spécifiques qui permet à l'agent évaluateur lorsqu'il a évalué la personne, de dire quelle catégorie. Et cette catégorie-là sera corroborée par l'échantillon de substances corporelles qui a été pris, soit l'urine ou le sang. Ça arrive dans certains cas que l'agent évaluateur en vient à la conclusion que la personne n'est pas en capacité affaiblie, qu'il s'agit d'une exclusion médicale ou que c'est de l'alcool qui est impliqué dans la capacité affaiblie et non de la drogue. La deuxième méthode possible est l'échantillon sanguin. Donc, l'échantillon sanguin, le code criminel permet que, en plus de l'agent évaluateur ou en substitution à l'agent évaluateur, on peut donner l'ordre à la personne de fournir un échantillon sanguin. Au Québec, on n'utilise pas ce pouvoir du code criminel-là d'emblée parce qu'actuellement, seuls certains professionnels ont le pouvoir d'effectuer les prélèvements sanguins. Nous n'avons pas d'entente contractuelle avec des ressources externes. Et au niveau des substances que je vous parlais dès le départ, là, avec les taux détectables dans le sang, ce sont des substances qui sont illicites à l'exception du cannabis. On sait que plusieurs personnes conduisent leur véhicule sur des médicaments d'ordonnance pris en grande quantité qui font en sorte qu'ils se retrouvent en capacité affaiblie. Donc, lorsqu'on a un échantillon de sang seulement et qu'on se trouve dans des substances, dans les médicaments d'ordonnance, c'est un peu plus difficile de démontrer la capacité affaiblie de la personne parce que c'est des médicaments d'ordonnance tout simplement qui se trouvent dans son sang et on n'a pas le taux, on n'a pas la quantité. Donc, aussi au Québec, lorsqu'il y a une évaluation par un agent évaluateur, on a le pouvoir de restreindre la conduite de la personne au niveau du Code de la sécurité routière pour une période de 90 jours et d'appliquer une saisie du véhicule si la personne est en récidive. Donc, ce sont des pouvoirs propres au Québec en matière d'agents évaluateurs et c'est pour cette raison qu'on utilise ce pouvoir-là. Les enjeux que nous avons actuellement en matière de dépistage de capacité affaiblie par la drogue, c'est vraiment la formation, la disponibilité, la rétention et le déploiement des agents évaluateurs en reconnaissance de drogue. Nous avons actuellement au Québec environ 150 agents évaluateurs en reconnaissance de drogue pour l'ensemble de la province, dans les corps de police municipaux et ainsi que la Sûreté du Québec. Donc, c'est peu de ressources pour un énorme territoire et pour une demande de plus en plus élevée en agents évaluateurs. Donc, on doit en plus aussi continuer de former les patrouilleurs de première ligne dans le dépistage des conducteurs intoxiqués. Les policiers sont habitués avec l'alcool au volant. Par contre, la drogue, on doit donner de plus en plus de formation à reconnaître les signes et symptômes d'une personne intoxiquée par la drogue. C'est un enjeu actuellement dans les organisations policières. On doit aussi développer des ententes pour accroître l'accessibilité aux prélèvements sanguins, parce qu'actuellement, on n'a pas d'entente avec les organismes externes. On doit aussi rester à l'affût des développements technologiques dans les outils de dépistage des conducteurs intoxiqués. On parlait du MDDA tout à l'heure. C'est sûr qu'on on aimerait avoir un outil plus stable, plus performant, qui nous permet de détecter en temps réel que la capacité de conduite de la personne est affaiblie. C'est un outil qui pourrait être intéressant pour l'avenir. On veut aussi développer de nouvelles stratégies d'intervention en matière récréo-touristique, soit quad, motoneige, nautique. On observe de nombreux comportements à risque dans ces moyens de transport-là et on développe de plus en plus notre stratégie d'intervention à ce niveau-là. Et on doit aussi rester à l'affût des exigences légales des tribunaux pour les droits garantis des conducteurs arrêtés, les délais liés entre l'arrestation et l'évaluation. Ce sont là plusieurs items que nous devons vérifier pour s'assurer de rester à l'affût et intervenir adéquatement en matière de capacité affaiblies. Au niveau statistique, on remarque depuis 2016 une hausse du nombre d'évaluations par les agents évaluateurs. Donc, les agents évaluateurs en 2016 effectuaient 831 évaluations au Québec à chaque année. Ce nombre a passé à 1611 en 2020. Donc, on remarque une hausse de plus de 94 %. Ça a presque doublé dans les 4 dernières années, le nombre d'évaluations effectuées par un agent évaluateur au Québec. Au niveau des conclusions de l'agent évaluateur, lorsque celui-ci effectue son protocole en 12 étapes, il doit émettre une opinion. On se rend compte que c'est assez stable au niveau des substances qui sont dépistées par l'agent évaluateur. En première place, on a les stimulants du système nerveux central, vient ensuite les dépresseurs du système nerveux central et en troisième place, on a le cannabis qui nous intéresse aujourd'hui. Donc, on parle c'est d'environ 39 % des dossiers, entre 37 et 39 % des dossiers effectués au Québec que le stimulant du système nerveux central est le plus souvent dépisté. On parle de méthamphétamine et cocaïne. Ensuite, ce sont les dépresseurs et en troisième place vient le cannabis avec environ 19 à 22 % des dossiers qui contiennent une opinion de cannabis. Au niveau des heures de l'événement de conduite avec les capacités affaiblies, on remarque que la conduite capacité affaiblie par la drogue se produit à n'importe quel moment de la journée. On a des événements de nuit et de jour. On parle de 56,8 % des événements de conduite capacité affaiblie par la drogue ont lieu entre 20 h et 7h59 et 8 h le matin. Donc, 56,8 % surviennent la nuit, tandis que 43,2 % surviennent le jour. Donc, c'est assez partagé. On s'attend parfois que ces événements-là se produisent plus la nuit, mais on voit que c'est à n'importe quel moment de la journée. Au niveau des moyens de détection, on remarque que dans 67 % des cas, des évaluations qui ont été réalisées, le policier a procédé à l'arrestation avec des motifs raisonnables de croire. MRC signifie motif raisonnable de croire, donc il n'y a pas eu à utiliser d'outils. C'était d'une évidence pour le policier que cette personne-là est intoxiquée par la drogue. Donc, les épreuves de coordination de mouvement ont été utilisées seulement dans 29% des cas. Au niveau de l'ADA, c'est le dépistage d'alcool en bordure de route. Et il y a aussi des fois des combinaisons avec dépistage d'alcool et épreuves de coordination de mouvement. Mais on remarque que principalement, les personnes sont arrêtées sans utilisation des outils. Au niveau du dossier ouvert, pour quelles raisons? On remarque que dans plus de 57% des cas, dans 57% des cas, la personne a été interpellée suite à un appel d'un citoyen. Donc, on remarque que les appels de citoyens sont une part importante de nos interventions en matière de capacité affaiblie. Les gens nous appellent pour rapporter des conducteurs intoxiqués. Et dans 38% des cas, c'était des dossiers initiés sur la route. Donc, suite à des patrouilleurs qui patrouillaient, qui localisent un conducteur, interceptent. Donc, c'est 57 et 38% respectivement. On remarque que sur les contrôles routiers planifiés, les barrages communément appelés, seulement 5% des dossiers de conduite capacité affaiblie par la drogue sont ouverts suite à un contrôle routier traditionnel. Donc, c'est vraiment plus les appels de citoyens et la patrouille. Au niveau du genre des personnes arrêtées, on remarque que dans 78% des cas de conduite capacité affaiblie par la drogue, ce sont des hommes impliqués et 22% des femmes. Donc, il y a vraiment une part importante d'hommes qui sont arrêtés pour conduite capacité affaiblie par la drogue. Donc, ça met fin à ma présentation. Donc, je vous remercie beaucoup pour votre attention et puis j'espère avoir répondu à certaines interrogations.
Thank you, Matthew. That was very interesting. I would say that if you want to look in the Q&A section on the bottom of your screen, there's some questions that have come in specifically for you, which we can try to answer at the end. But in the meantime, we're going to turn to Wendy Thompson, who is an epidemiologist with the Center for Surveillance and Applied Research from the Public Health Agency of Canada. She's going to talk about trends related to cannabis and motor vehicle crashes. So, Wendy.
Thank you very much, everyone. One of the things that I wanted to thank Paul for the introduction, as well as the organizers to have me, and as well as all of the 100 participants. So that's pretty exciting. Aussi, merci Mathieu d'avoir introduit le sujet des autres drogues et aussi la combination des drogues et de l'alcool. So we've talked about from turf, and I love doing work and collaborating with Robin, Ward, and Steve as well. So they've talked about and presented fatalities. We talked about with Ken and Robin's survey data and Matthew police data. So here I am talking to you about health data. So we're looking at motor vehicle collisions, injuries, and hospitalizations, but that are presenting to both hospitals and emergency departments in Canada. And I am trying to also move my screen forward. I apologize. I don't see, oh, there we go. So the data sources that we look at for hospitalizations, we get this data from the Canadian Institute for Health Information. Hospitalizations for the data set we have are called discharge abstract data. And although for emergency departments, it is called National Ambulatory Care Reporting data, we will only have full provincial coverage for Ontario, Alberta, and Yukon. And in this slide deck, we're only going to be presenting Ontario and Alberta. We talk about fiscal years, so beginning April 1st, 2010. So we're looking at an 11-year period. So we will look at motor vehicle collisions as a whole, and then those related to substance use. So when we're talking about motor vehicle collisions, we will include the driver or passenger in the vehicle, but we also look at other pedestrian or cyclist using the road. So we have excluded our water and air transport collisions. First, setting in a context. So we're looking at hospitalizations. This is hospitalizations, and I apologize. I'm an epidemiologist, I'm a manager, but I'm a big data geek, so that there is a lot of data that we're presenting. I'm going to be presenting in this slide deck, and a big thanks to my team for helping me pull it together in this time. So within this 10-11 year period, motor vehicle collisions has the second highest rate in cases for injury hospitalizations in Canada for all ages. Those with substance use, you can see where motor vehicle collisions fits in. So those are injury hospitalizations related to a substance. So this is over time. So though not shown, the hospitalizations for motor vehicles have declined, both by females and among males, which is good news. Those related to substance, and we talk about statistical significance, so though we might see a little bit of a decrease or a little bit of an increase, one, we have to take into the effect, and we'll have a little bit more confidence in the data up to 2019, 2020, because we're doing a lot of analysis and working with CII and provinces and territories on the effect of COVID. A lot of people weren't maybe on roads, but substance use has increased across the board for hospitalizations and emergency department visits during this time. So similar trends we're seeing among emergency department visits. So if you're familiar, and I apologize for just pay attention to a little bit on the scales, because if you look at the scales when we're looking at age adjusted rates, some of those scales might change for hospitalizations versus ED visits. And again, ED visits, we're looking at Ontario and Alberta. So we did see a decline in ED visits related to motor vehicle collisions among males. We're also, which was statistically significant, but we're also looking at females, which had a slight increase in rate. But then how does it look when we break it down by different age groups? So males, as you see, are still, so what this graph is showing are the injury hospitalizations associated with substances. So you're looking at, for the combined for those 10-year period, males still dominate. They still have a large percentage of those substance use associated NVC hospitalizations, and then you have females across the board. Certain older age groups are a little bit higher, but the predominant are between the 10 to 29 age group. Keep in mind, we have included both passengers as well as drivers. So future work will be disaggregating them, but this includes anyone that was hospitalized that were and in hospitalization data as well as emergency department. It's using the ICD codes, which are the International Classification of Disease codes. And this is anyone related to a substance with a motor vehicle collision. That can either be the driver and or passenger. Then we're looking at now just breaking it down by road type. So you see predominantly car, but when you're having a collision, it could be on the road related to substance, you do have cyclists, pedestrians, as well as motorcycles. So this is broken down. We've separated out males and females. We're still looking at hospitalization. So those that were hospitalized, not treated in the ED and released, these were hospitalizations for this 10-year period among the different age groups related to substance, broken down by car, cyclist, pedestrian, and or motorcycle. Keep in mind, if you don't see, let's say, small cell counts based on our agreements, we don't release cell counts less than 5. So do not assume that anything less than for the younger age groups are a 0. They just have less cell sizes that we actually need to suppress due to our data sharing agreements with CIHI. So when you break it down to look at hospitalizations with substance use by road user, when you're looking at it, this is across the ages. So car predominantly has the highest rate of hospitalization for those 10-year periods. And then we have breaking down again, pedestrian, cycle, other land transport, and motorcycles. So there's a slight increase in motorcycles. We have included the confidence interval. And for those of you who are familiar with it, I don't have to tell you, but if the interval includes 0, it passes negative to positive of 0. We don't actually consider this statistically significant, but there is a change. And because we're looking at national data, definitely some things to keep in touch with. So when you're looking at substance categories though, because we're interested in also a lot of substance related harms, where does that fall? Where does cannabis fall in with other drugs as well as alcohol? So for hospitalizations, for injuries related to motor vehicle hospitalizations, substance use, alcohol is still over 50% of the categories. Now then you have a rise in opioids. We did not break this data down by province and territory. That will happen for hospitalizations shortly. But when you're looking at polysubstances, that can include cannabis, that can also include alcohol. So we're breaking it down. Again, we can only do stats as well as the data provides. So we're looking to see what details are in polysubstances. Other drugs do not have their own international classification of disease code, so they are lumped in under other psychoactive substances and other stimulants. So keep in mind, you have 6% related to cannabis or cannabinoids, almost 11% related to opioids, and over 60% related to alcohol. And then we see the increase of polysubstances across all ages, both for males and females. So how does it look when we look at emergency department visits? Again, Ontario and Alberta for that 10-year period, alcohol is still the predominant. You have polysubstances, etc., and you're at 3.4% for cannabinoids. Keep in mind, polysubstances can also include cannabis. A lot of them include alcohol plus another drug. So when you're looking at over time, how does that look at for substance, motor vehicle substances broken down? So as we've indicated, or as I've shown for injury hospitalizations and emergency department visits, overall, those are decreasing related to motor vehicle collisions. Alcohol is a predominant drive of that factor, is that alcohol is still high, it's still of a concern, has decreased over the 10-year periods. But then it's to say, what is on the rise? Are we there yet? Can we keep alcohol-related motor vehicle collisions decreasing, the hospitalizations, deaths, and emergency departments related to? And then how do we look at the effects of other ones when we break it down, polysubstance, opioids? Cannabis was at 1.2% increase, so it's not shown here. You have polysubstance use, opioids, and other psychoactive substances. They are increasing and they are statistically significant looking over those 10-year periods. So they are on the rise, even though alcohol is decreasing. The similar effect with emergency department visits, we have removed the alcohol. The trend for alcohol is not shown on this. The decline is about the same for alcohol-related ED visits as it was for hospitalizations. We have zoomed in a little bit more to be able to show the effect a little bit clearer in this slide for polysubstances and the other type of drugs, including opioids. So this is where cannabis, you'll see in the emergency department visits, is presenting at 8.2%. So though we might not have seen it in the hospitalizations, we have seen it in Ontario Ontario and Alberta. And that's not to say that other provinces are not seeing the same in their emergency department visits, but just currently CIHI has all hospitals and all emergency department visits reporting to them to be able to get full rates as well as case numbers for all hospitals in that province. So we have seen, as I've indicated, motor vehicle collision injury hospitalizations, as well as ED visits decrease, as well as those associated with substance use. Males account for 3 times as many injury hospitalizations, as well as ED visits with substance use as compared to females. You have from driving in a car, the substance use peaks at 20 to 29. The 15 to 19-year-olds are also high, both for males and females. And then this slightly changes. You still have alcohol involved in more than 50% of these cases, but then you need to be a little bit, different drugs are used more predominantly, or we've seen it more predominantly when we look at just substance harms in general for different jurisdictions. So that will be something that we are going to be looking at. And you also have the rate of those hospitalizations as well as those ED visits slowly increasing. So though efforts have been made or successes have been made to reduce motor vehicle hospitalizations, as well for emergency department visits, particularly those for alcohol, you do see an increase in other substances, and all of those are increasing. So not just one might be more predominant than the other, but they all are being seen at hospitals related to MVCs more over the last 10 years than they have been. So then I say, so what? In the federal government, we're always trying to say the number or the hook. What can we do about this? So Ken had presented definitely the fact that we can't do it alone. It's federal level. I can show you the hospitalizations. The road data, the road safety data, the police data is also significant to be able to give us that context, because I can only see if you were hospitalized and if you were admitted to the emergency department, but that does not mean other events didn't occur that might have been or could have been a lot more fatal or related to harms than they were. So this is where we go into, some of it is we're always wanting to know, or I've been asked, let's say, what are the costs? So we collaborated, or Public Health Agency collaborated with Parachute. And you can go, and this is an interactive tool that you can look at the cost of injury. So though we haven't broken down the cost of injury related to transport incidents by substances, we have looked at the cost of injury, and this is our 3rd or 4th time being able to look at this with BC Injury Research and Prevention Unit, looking at different models for costs, because I'll be able to say what the rates were, and can present all of these statistics, but sometimes it's important to look at the cost of injuries, looking at hospitalizations. So when you're looking at it, though falls across all ages in Canada have a high rate of cost, transport incidents are quite significant. So reducing, if you want, I guess, a little bit more reason to showcase to anybody of why this is important to continue to reducing, not only for the lives lost, the injuries, the hospitalizations, but then we have associated direct and indirect costs. You can go and you can break down different age groups. You can break it by males and females, and then you can look at the total costs. So we're looking at here the different age categories, and you can see related to death, hospitalization. So if you're looking at the 3rd level, transport incidences for deaths, hospitalizations, and ED visits, as well as disability. So this is just with the data that we have access to at the national level, but to be able to provide it. Broken down, motor vehicle, other transport, pedestrian, pedal cycle, and we did include ATV and snowmobiles. So again, you can go around and play with it, but not one data source can tell you the whole story. It is in collaboration with all of the data sources together that will piece and provide stronger evidence And you also sometimes need to do the deeper dives, because at a national level, looking at all ages across Canada or all jurisdictions might not get to where policies and programs, different legislations, and where the burden is seen at most. When we're talking about PYLL, for those of you that aren't aware, it's person years of life lost. The impact to the population and to the society for one individual death is higher for a younger age group. So when you're looking at the motor vehicle collision hospitalizations, fatalities and emergency departments, but particularly when you look at the fatalities and knowing that the highest rate occurs in the younger age group, that is the more significant loss of life in terms of cost effective, to be able to the impact to the cost to the Canadian society and to the economy. So this is why, and also another reason for it's important to be actually able to reduce motor vehicle collisions as a whole, but also the increase in awareness, prevention, programs to be able to reduce it definitely for those younger age groups. They're also the ones that are most at risk. They're the ones most involved in the fatalities and the substance use for both motor vehicle collisions as a whole, but also those related to substance use. So this is just some further analyses and explorations. Thank you very much. If you do have any questions, and I know that was a lot to provide and a lot to go through, but again, thank you very much, and please let us know, because this was a fantastic opportunity to show how all data combined working together can create that, that bigger picture.
Thank you, Wendy. Now I'd ask all the speakers to turn their cameras on, and we have some questions that have come through. Let's see what we have here. One question is probably from Matthew. How do police officers assess polydrug consumption? Matthew?
Donc, au niveau de la consommation de plusieurs substances, lorsque l'agent évaluateur est en ligne de compte, lorsque l'agent évaluateur évalue la personne, ceux-ci sont formés et apprennent les effets et les signes et symptômes attendus lorsque plusieurs substances sont consommées. On appelle ça la polyconsommation. Donc, parfois, ils peuvent émettre un ou deux ou plusieurs opinions sur la catégorie de drogue consommée. Il y a certaines combinaisons de drogues qu'on voit fréquemment, le cannabis avec un stimulant du système nerveux central ou d'autres types de drogues. Donc, les policiers peuvent émettre deux opinions qui seront validées par la suite par la toxicologie.
Thank you. Let's see what else we have here. There's a question for Wendy about exploring the differences between Alberta and Ontario. They're interested in the slide 14, since increases are observed in hospitalizations.
We are looking at, so hospitalizations we can look at, and as one of the, as I mentioned, we will be looking at for the different jurisdictions. For emergency department visits, the difference between Ontario and Alberta, we will also be exploring. When you're working with the federal government, we also might like to so we are developing a paper with this data. So that's why I was so excited to be able to present it, because it gave us a chance to do this deeper dive in anticipation. So yes, we are anticipating looking at that, as well as the effects of seasonality and weekends, but we haven't just yet, so stay tuned.
Wendy, can you provide more information regarding how the data regarding MVCs associated with substance use is collected in Ontario and Alberta?
How it's collected? We don't have we know it's a flag. So what we see. There are toxicological tests taken and tested with at the hospital. However, not all of these are recorded. At the level of data that we see, again, it's based on ICD codes, so they just flag if it was present and or related to. So we're doing a deeper dive with Canadian Institute of Health Information, CIHI. It's the data that they collect from the provinces and territories to be able to find out a little bit more. So it is collected on the charts, but what we see is just the code of if it was part of that injury hospitalization or the MBC hospitalization or ED visit. So we don't have the same levels of the alcohol concentration levels or the other concentration levels. Let's say that Mathieu was presenting from a police standpoint, or that Robin was presenting that Turk gets from the fatality data.
So here's a question that perhaps everybody can take a shot at. You've all presented a lot of data, a lot of very valuable data from your perspectives, but the last 2 years have not been normal. So how do we interpret the data that you have now in terms of planning and going forward based on the last 2 years? Perhaps we can start with Robin.
Thanks, Paul. Good question. I think looking at some of the self-reported behavior changes that we're seeing as a result of the pandemic on top of legalization with some of those increases, I think it's more important than ever to understand who's engaging in the risky behaviors and more about kind of what influences their behaviors, whether it's, you know, changes as a result of the pandemic, whether it's changes as a result of legalization, whether attitudes and norms are shifting. So I think tracking that issue closely will be important going forward, because it's easy to see what the data show us. The harder part is interpreting what exactly that means to help us figure out where we need to go from there.
Ken?
If I look at it from an insurance perspective, many of the trends we're seeing in our opinion surveys remain the same. We have seen a change in frequency because of driving habits changing more around when people are driving, but I'm not sure that we can conclude that their actions as it pertains to the things we're talking about here have changed that dramatically. So I'm not sure how much, if I look at COVID and some of those changes, how much it really changes some of the needs and the opportunities for us to continue with the education and awareness opportunities and to continue to work collaboratively and collectively together to tackle the problem.
Thank you. Matthew, how does the police
Donc, au niveau
deal?
de la collecte de données, effectivement, il y a eu plusieurs choses dans la dernière année qui ont fait en sorte que les données peuvent ne pas être exactement refléter le portrait qu'on va avoir dans le futur. Si on regarde au Québec, pendant plusieurs mois, on a eu un couvre-feu. On se rappelle que beaucoup de comportements en matière de capacité affaiblis par l'alcool et les drogues se produisent la nuit, pendant que c'était une période de couvre-feu. Donc, nos données sont peut-être un peu à la baisse sur ce qu'on va avoir dans les prochaines années. Donc, on reste à l'affût de qu'est-ce qui va se passer. Cet été, on a mis sur place un projet d'intervention en matière de capacité affaiblie par la drogue, justement en réponse à la fin du couvre-feu et les mesures des confinements. Donc, on reste vraiment à l'affût de ce qui va se passer dans les prochains mois, prochaines années pour la collecte de données.
Wendy, last word to you.
Behavior change is tricky, and though I would love to be able to say that certain behaviors have changed, we don't quite have a reason to believe that they have just yet. So we're going to need to keep looking at it, because what we don't know is, even though alcohol is decreasing, are those the same individuals that other substances? And so we still have to continue our efforts to reduce. the numbers, increase awareness, and look at other options. And so though we're hopeful and collectively the data together might showcase a little bit better, but all efforts are needed to be able to look to see what the future looks like.
Thank you. I'd like to start by thanking all the presenters for great presentations. There was a lot of great information there. People asked if the slides will be available. Yes, they will be available at some point in the near future. You can go back and review it and pick up a lot of the numbers you may have missed going by at the time. In the meantime, I would encourage you to attend the meet and greet Cannabis and Driving Research and Opportunities to Reduce Risk immediately following this session. Desjardins and Turf are hosting this 30-minute discussion and Q&A on cannabis and road safety. You can interact with the presenters that are available and the cannabis and driving prevalence and research needs. I would also mention that the CARSP AGM for any CARSP members or wannabe members is at 3:30 this afternoon. And I'm told there will be gamification codes available during that session, so it might be worth showing up. The Students and Young Professional Symposium event, there's a virtual walkabout, Vision Zero in Montreal. The Vision Zero Road Safety interactive presentation will take occupants or participants through some of the key elements put in place by the road safety team of the City of Montreal. You can check the program for more details. I thank all the presenters for the great presentations. I thank everybody for their attention and their questions, and enjoy the next session. Thank you.
Thank you.